Welcome to Deep Dive Ortho. Upper extremity orthopedics is, I think we can agree, one of the most demanding corners of our field. We're in this constant balancing act, aren't we? We need rigid stability for bone to heal, but we also have this absolute necessity of retaining mobility, retaining function. And it's all set against this backdrop of highly visible anatomy and, of course, the ever-present expectation of optimal patient satisfaction. It's a space where the slightest refinement in technique can make a monumental difference. Today, we're embarking on an in-depth exploration of some critical and I think highly nuanced topics in forearm and clavicle management. We'll be navigating everything from some really rare complications linked to modern anti-osteoporotic medication, all the way through to the latest evidence comparing surgical approaches for common clavicle breaks. It's a dive into the evidence that I think should genuinely challenge some of our established surgical habits. And to guide us through this complex clinical data, I'm delighted to welcome our expert to the deep dive.
Thank you. It's a genuine pleasure to be here. You're absolutely right. The upper limb, and particularly the forearm and the wrist, it demands such precision. The functional demands placed on this anatomy mean we really can't afford generic, one-size-fits-all treatment plans. We have to constantly be integrating new guidelines, new comparative studies, and all these subtle pathoanatomical insights into our practice.
Okay, let's unpack this. And we're starting with a pathology that is gaining, I'd say slow, but truly concerning recognition outside of its classic presentation. We're talking about the atypical fracture syndrome, but specifically occurring in the ulna.
Yes, and it's intimately tied to severely suppressed bone turnover.
So for decades, when we heard atypical fracture, our minds immediately went to the femoral shaft, the subtrochanteric region, atypical femoral fractures, AFFs. But now we're seeing this evidence, albeit rare, of this pathology cropping up in the ulna. So could you start by just laying the groundwork for us? Define the underlying biology of the syndrome. Why is it linked to the very drugs we use to treat osteoporosis?
That really is the critical starting point. Atypical fractures, or AFs, are inextricably linked to the long-term use of bisphosphonates. These are, potent anti-resorptive agents. And while the femur is the primary site and accounts for the vast majority of cases, the pathology itself is universal. It's systemic. The mechanism is really a perfect storm of two factors. Firstly, you have severely suppressed bone turnover, or SSBT. Bisphosphonates work by inhibiting osteoclasts, the cells responsible for bone resorption. By doing this so powerfully and so consistently over many years, we reduce the rate at which bone is removed.
So the bone density improves on the scan, which is the therapeutic goal.
Exactly. That's what we want. But the critical side effect is this SSBT. The second factor is the accumulation of chronic repetitive microdamage. Every movement, every time you use your arm, you create tiny microcracks in the bone structure. Normally, in a healthy bone remodeling cycle, osteoclasts detect these microcracks. They remove the damaged bone, and then the osteoblasts come in and fill the gap with new healthy bone.
A constant repair process.
A constant repair process. But when that turnover is severely suppressed by the BPs, the microcracks just accumulate faster than the body can repair them.
So we end up with this bone that looks dense on a DXA scan, but is actually physiologically fatigued. It's structurally compromised. It's more of a material failure than a deficiency failure.
Precisely. That's a perfect way to put it. It's the result of inhibited biological repair. And this accumulation of microdamage leads to these areas of high stress concentration, and then eventually a crack propagates. Now, when we look at atypical ulnar fractures, AUFs, they are exceedingly rare. I mean, the most recent comprehensive review suggests only about 14 cases have ever been documented in the English language literature.
14? That's tiny.
It is. But every single case is a warning sign. It confirms that the mechanism of SSBT and microdamage accumulation is not site-specific. It's a systemic risk linked to drug exposure. We have to maintain vigilance, especially in patients with chronic, nonspecific pain in the forearm who also have a long bisphosphonate history.
That rarity makes the radiological picture the absolute key then. We can't rely on incidence. So what are the radiological and clinical fingerprints that should immediately raise suspicion for an AUF? The things that make you think, hang on, this isn't just a standard fall on an outstretched hand injury.
Yes, and we must educate our non-specialist colleagues, and indeed ourselves, to look for these highly specific characteristics. They mirror the AFFs, but they just look fundamentally different from a typical trauma-induced fracture. Firstly, they are typically non-comminuted. The bone doesn't shatter into multiple pieces, it cracks cleanly. Secondly, the fracture orientation is almost always short, oblique, or transverse. This is a sharp contrast to the spiral fractures you see in torsional trauma.
Right.
But the absolute hallmark, the real red flag, is the precursor lesion. You see cortical thickening and sclerosis right at the fracture site. You see this localized hypertrophy of the cortex, often involving the entire width of the ulna. And this represents the bone's futile attempt to repair the fatigue damage without the necessary remodeling capacity.
So the body is just stacking on more material because it can't replace the faulty material.
Exactly. This sclerosis indicates bone that is really struggling to turn over. And this precursor sign is so vital because it offers a small window, an opportunity for proactive intervention before a complete fracture occurs.
That makes perfect sense. And we saw a particularly complex scenario reported in an 86-year-old woman who sustained bilateral AUFs. That case is fascinating because it really illustrates the challenge of managing patients after they come off bisphosphonates and go on to an anabolic therapy.
That case is highly instructive. It really encapsulates the complexity of modern osteoporosis management. This patient had a history of long-term BP use and had then been switched to 2 years of teriparatide, which is an anabolic agent designed to stimulate bone formation.
So she was on the right track, pharmacologically speaking.
You would think so. Yet, she sustained bilateral AUFs, one complete and displaced, the other incomplete, following what was described as minimal trauma, literally sliding off a low seat. And her radiographs revealed that classic pattern, non-comminuted, short oblique, with this profound cortical thickening. It highlights a really critical point. Switching to an anabolic agent does not instantaneously reverse the structural fatigue damage in the SSBT caused by years of BP use. It takes time for that bone repair mechanism to regenerate and catch up.
So the damage is already done, essentially.
The accumulated microdamage remains a significant risk factor until sufficient remodeling has occurred.
Which brings up the whole controversial area of the drug holiday. When a patient has been on BPs for, say, 5 to 10 years, we often recommend a holiday to mitigate this SSBT risk. What is this specific pathology, the continued risk, even after 2 years of teriparatide? Tell us about the timing and efficacy of these drug holidays. Are they enough?
Well, it tells us that our monitoring of SSBT recovery is, to be blunt, quite crude. And that the risk accumulated during BP therapy is tenacious. It's very sticky. The standard recommendation is often to stop BP therapy after 5 years for lower-risk patients or 10 years for high-risk patients, and then monitor bone turnover markers and density.
But how do we define recovery? That seems to be the key question.
That is the challenge. If the structural integrity is already compromised, if the bone has effectively reached a pseudo-fatigue state, simply stopping the BP may prevent further suppression, but it doesn't instantly repair the existing microdamage. Teriparatide or other anabolics are meant to jumpstart that remodeling, but the rate of structural repair deep within the cortex may lag significantly behind what we see in the biochemical markers.
So the blood tests might look good, but the bone is still vulnerable.
Precisely. For a patient with an existing stress reaction, that cortical thickening we just discussed, many surgeons would argue that a drug holiday is completely insufficient. They require immediate intervention, possibly with anabolic agents, and rigorous protection until that stress reaction resolves on imaging. The difficulty is predicting which patients are at residual risk years after they've stopped the drug. It's a real diagnostic dilemma.
So if we do confirm an AUF, and we know this bone resists normal healing, what are the established treatment protocols? Are standard plates and screws going to be sufficient, or do we need to pay special attention to the biology of the situation?
No, standard fixation is definitely not enough. These fractures occur in bone that is metabolically inert, pathologically sclerotic. Non-union is a genuine and very serious threat. So the surgical principles have to be dual purpose. You need rigid internal fixation for mechanical stability, of course, but critically, we must also mechanically treat the underlying osteosclerotic lesion.
We have to become the remodeling agents that the patient's own biology cannot be.
That's exactly right. The technique often involves drilling multiple small holes through the sclerotic cortex, a process known as bone fenestration, using a K-wire or a fine drill bit. This is then combined with curettage of the sclerotic bone at the fracture margins. The goal is twofold: to debride the dead, unreactive bone, and to penetrate the cortex to expose the healthy cancellous bone underneath, which stimulates local bleeding and hopefully initiates a healing cascade.
So you're creating a window for revascularization and biological activity, and I assume you then need to bridge that with something more than just plate compression.
Absolutely. The debridement and fenestration are typically combined with an autologous cancellous bone graft. A common harvest site, conveniently, is the ipsilateral olecranon. This graft is vital. It provides local osteoinductive, osteoconductive, and potentially osteogenic cells right where that SSBT is most pronounced. This aggressive local biological intervention is, in my view, non-negotiable for ensuring union.
And postoperatively, what's the role of systemic management? If we're treating this with surgery, surely we must also address the systemic cause pharmacologically.
Yes, the two must go hand in hand. If we have used surgery to achieve mechanical and local biological stability, the systemic management has to support that. If the patient, like the 86-year-old in that case, cannot take or continue anabolic agents, then our non-operative modalities pivot to promoting local union physically. So things like low-intensity pulsed ultrasound or LUFI uses. This has shown some promise in non-union and challenging fracture scenarios. It offers a non-invasive way to mechanically stimulate healing.
And then what about their long-term osteoporosis management?
The subsequent medical management has to focus on agents that promote bone formation and turnover, while rigorously avoiding any further anti-resorptive agents until there is clear, undeniable evidence of fracture union. This is where the orthopedic surgeon must work very closely with the endocrinologist or the osteoporosis specialist to map out a safe and effective post-operative drug regimen.
It's an exhausting level of detail, but absolutely necessary for these complex cases. It really reminds us that a patient's drug history is just as important as their X-ray. That insight into suppressed biology leads us quite naturally to the next point. What happens when the surrounding biology and anatomical constraints are completely intact, as in the classic isolated nightstick fracture? We're moving now to a far more common fracture pattern, but one where the debate over surgical versus non-surgical intervention is still highly active. The isolated ulnar shaft fracture, the nightstick fracture. It's almost legendary due to its typical defensive mechanism. But before we get into the debate about plates versus casts, let's nail the initial assessment. What are the absolute critical steps to confirm this fracture is truly isolated and not part of a much more complex injury pattern?
You cannot treat an isolated ulnar shaft fracture until you have definitively ruled out its much more unstable cousins. This is the first, and I would say the most critical, rule of forearm trauma assessment. We absolutely must rule out a Monteggia fracture, which is the ulnar fracture associated with a radial head dislocation,
Right.
and a Galeazzi fracture, which is a distal radial shaft fracture with an associated distal radial ulnar joint, or DRUJ, subluxation. Both Monteggia and Galeazzi injuries are inherently unstable, and they almost always require immediate operative management.
And the only way to do that is with good imaging.
Correct. Standard AP and lateral views of the forearm are necessary, but they must unambiguously include the entire length of the radius and ulna, and I mean extending right through to the wrist and the elbow joint. Specifically, on the lateral view of the elbow, the radial head must be perfectly aligned with the capitulum. If it isn't, or if there's any suggestion of angulation, you must treat it as a Monteggia until proven otherwise. Similarly, at the wrist, AP and lateral views are crucial to assess the DRUJ for any signs of widening or subluxation.
That comprehensive imaging requirement is so often forgotten in the rush of the A&E department. So assuming we have a true isolated ulnar shaft fracture, its stability really hinges on the anatomical constraints around it. What role do the intact radius and the interosseous membrane play in our decision-making?
They are the entire basis for non-operative management. In an isolated ulnar shaft fracture, the radius is intact. The radius acts as a rigid load-bearing strut, which prevents any significant collapse or shortening of the ulnar fragment. And crucially, the interosseous membrane, or the IOM, particularly its central band, remains intact. The IOM connects the radius and ulna, and it's vital for load distribution.
So it acts like a tension band.
A very powerful one. If the IOM is undamaged, it maintains the precise distance between the radius and ulna, preventing the interosseous space from collapsing and acting as a powerful rotational and axial stabilizer for the ulna fragments. Therefore, if the fracture is non-displaced or only minimally displaced, and the general cutoff here is less than 50% displacement and less than 10 degrees of angulation, the inherent stability provided by the intact radius and the tensioned IOM often provides a sufficient mechanical environment for predictable healing without any surgical intervention.
Which brings us squarely into the modern debate. For these selected, minimally displaced injuries, is a long arm cast or functional bracing truly equivalent to or RIFF with a plate? We have some comparative data that shows some interesting trade-offs, particularly regarding time.
Indeed, there was a well-designed prospective study that specifically compared ORIF using compression plates against long arm casting for these isolated ulnar shaft fractures. And the findings provided some clarity, but they also presented a significant dilemma for the surgeon and, of course, for the patient. On the purely radiographic and biological metric of healing time, ORIF was the clear winner. The mean time to radiographic union was significantly faster in the ORIF group. It was clocking in at approximately 13 weeks.
13 weeks. In the CAS group?
That contrasts with the CAS group, which took about 18 weeks to reach union.
18. Okay, so that's a 5-week advantage for time to solid bone healing. It undeniably favors surgery on that metric alone, but I have to challenge the clinical significance there. A 5-week difference is statistically significant, yes, but for an office worker, perhaps they appreciate that 5 weeks. For a manual laborer who's going to require extensive rehabilitation anyway, is the surgery truly justified purely for that time gain? Especially when you consider the inherent risks of anesthesia, infection, potential hardware removal.
That is the perfect question.
Well,
And it highlights precisely why we must look beyond just the time to union. When the investigators looked at long-term functional outcomes at the 12-month mark, measured using reliable metrics like the DISH score, grip strength, and range of motion at the wrist and elbow, the results were statistically identical between the ORIF and the casting groups.
identical.
Statistically identical. This is the core dilemma. Surgery gets you there faster, but non-operative management gets you to the exact same functional outcome in the end. For the patient, this means the primary advantage of ORIF is a slightly accelerated return to early function, but they have to accept the, albeit small, non-union risk, the risk of surgery itself, and the high likelihood of requiring a second operation for hardware removal.
And what about the complication rates? How do they stack up beyond that functional equivalence?
The non-union rates were slightly lower for plating, somewhere in the 0 to 2% range. That's compared to non-operative management, which is about 2 to 4%. So ORIF is marginally safer from a healing perspective.
A small advantage.
A very small one.
Yeah.
However, a crucial caveat emerges when you consider different operative approaches. If the surgeon opts for intramedullary fixation and IM nail instead of compression plating, the non-union rate paradoxically jumps higher, often up to 5%.
Why is that?
It's almost certainly because an IM nail provides less robust rotational and axial stability compared to a well-contoured compressed plate. So the evidence really steers us strongly towards compression plating if we're going to operate.
Given that long-term function is equivalent and the non-operative risks are minimal, the focus should then shift to optimizing that non-operative management. Let's delve into the rationale for functional bracing. It seems to offer a significant improvement over traditional rigid long arm casting.
Functional bracing is a really elegant application of mechanobiology in trauma care. It rejects that outdated concept that the joints above and below the fracture must be rigidly immobilized for months on end.
Which, as we know, inevitably leads to severe stiffness and muscle atrophy.
Exactly. The entire rationale is predicated on the fact that controlled, low-strain motion at the fracture site actually stimulates healing. It's a concept related to Wolff's Law. Specifically, the mechanical stimulus provided by controlled movement encourages osteogenesis. Functional braces, like the Miami brace or the various Sarmiento designs, are very carefully engineered. They provide strong circumferential soft tissue compression.
So they act like a hydrostatic cast.
Precisely.
Yeah.
Which significantly stabilizes the fracture fragments, especially against transverse displacement. However, they're designed to leave the wrist and the elbow completely free to move.
So the patient retains their range of motion, which is crucial for preventing stiffness, but the fracture site itself is held tightly by that compression. What are the specific biological gains from this controlled movement?
The benefits are multi-layered. Firstly, preventing joint stiffness means significantly less time is needed in physiotherapy after treatment. Secondly, early mobilization maintains muscle mass, preventing the atrophy that complicates recovery. And most importantly, controlled motion increases local vascularity around the fracture site, bringing in all the necessary healing factors, oxygen and cells. It also introduces these low-magnitude stress signals that encourage the bone callus to mineralize faster and remodel more effectively. For midshaft and distal ulnar fractures that meet those minimal displacement criteria, functional bracing is a reliable, low-risk modality that completely bypasses any surgical risk.
Given the efficacy and low complication profile of functional bracing, I assume there are still some very strict contraindications where we absolutely must operate. What are those red lines for the nightstick fracture?
Yes. The moment you lose that intrinsic stability provided by the intact radius and IOM, you must operate. The main contraindications for non-operative management are, firstly, displacement exceeding 50%. At that level, the forces overwhelming the IOM are just too great to guarantee reduction maintenance in a brace. Secondly, angulation greater than 10 degrees, especially if it significantly impedes forearm rotation.
function becomes the issue there.
Yes. Thirdly, rotationally unstable fractures. And fourth, as we discussed, any associated instability. If a Monteggia or Galeazzi injury is even suspected, let alone confirmed, non-operative management is off the table. And finally, in polytrauma patients, early ORAF allows for safer handling, mobility, and prevents secondary complications.
That provides a very clear, evidence-based algorithm. Functional bracing for the stable fracture, compression plating for the unstable one, and a firm rejection of intramedullary nails. We've covered acute trauma and the pathology of rare chronic bone issues. Let's now pivot to a highly common chronic source of pain that demands meticulous measurement and precise surgical technique. Ulnar impaction syndrome. We all have that patient who comes in and just cannot seem to shake that ulnar-sided wrist pain, often exacerbated by power grip and rotation. When we discuss ulnar impaction syndrome, or UIS, can you break down the pathoanatomy? What exactly is grinding against what in there?
Ulnar impaction syndrome, or ulnocarpal abutment, is fundamentally a mechanical problem. It's caused by a length mismatch in the forearm. It results from what we call positive ulnar variance, and that simply means the ulna is structurally longer than the radius at the distal articulation of the wrist. The grinding occurs between the distal ulna head and the proximal carpus. Specifically, it involves the ulnar-sided carpal bones, the lunate, and the trachytrum, and their associated cartilage. Additionally, the ulna head repetitively impacts and macerates the delicate triangular fibrocartilage complex, the TFCC.
Which is the primary shock absorber on that side of the wrist.
It is. It's the shock absorber and the primary stabilizer. And this chronic mechanical impact leads to three main pathological consequences: painful degenerative tears of the TFCC, chondromalacia or erosion of the lunate and trachytrum cartilage, and eventually subchondral sclerosis or cysts in the ulna head itself.
And what are the common reasons we encounter this positive variance? Is it usually something a patient is born with, or is it more commonly secondary to previous trauma?
It's a mix, but I would say acquired causes are perhaps more frequently seen in orthopedic practice. Congenital or developmental factors include conditions where the radial growth plate closes prematurely, leading to a relative shortening of the radius. However, we must be vigilant for acquired causes, which are very frequently post-traumatic. The most common acquired cause is a malunion of a distal radius fracture, where the radial length has collapsed or shortened.
I see.
Other high-energy injuries, such as an Essex-Lopresti injury, which involves a radial head fracture and IOM disruption, can lead to migration of the radius proximally. This creates a profound positive ulnar variance, which can be hugely debilitating.
Diagnosis relies heavily on clinical assessment and precise imaging. Can you elaborate on the importance of that ulnar variance measurement? We hear so many stories about variance being mismeasured because of inappropriate X-ray positioning.
The clinical assessment is standard. The ulnocarpal stress test, where pain is reproduced during forearm rotation combined with ulnar deviation, is often positive. But imaging is where precision is absolutely paramount. Ulnar variance must be measured on a posterior anterior, or PA X-ray, and it has to be taken in neutral rotation and neutral wrist deviation.
Any deviation throws the measurement off.
Completely. Any pronation or supination will artificially shift the relationship between the radius and ulna, leading to mismeasurement. If that ulnar variance measurement is inaccurate, the surgeon may perform the wrong procedure or an insufficient correction. It's the foundation of the entire surgical plan.
We always attempt conservative management first, of course. But when do we know we've exhausted that pathway and the patient genuinely requires a surgical solution?
Conservative treatment immobilization, NSAIs, steroid injections, and strict activity modification is the standard initial approach. However, if the patient presents with severe functional deficits, markedly decreased grip strength, restricted forearm rotation, persistent debilitating pain, and those symptoms show no significant improvement after, say, 6 months or longer of dedicated conservative measures, then surgery is the recommended path. Prolonging non-operative treatment beyond that threshold often just risks further degenerative changes within the wrist joint.
So in surgeries indicated, the ulnar shortening osteotomy, or USO, has long been considered the definitive gold standard solution. What is the technical rationale behind performing the osteotomy in the shaft, and how strong is the evidence supporting this approach?
USO remains the definitive treatment, and it's supported by robust evidence, specifically Level 2B, which earns it a Grade B recommendation in clinical guidelines. The rationale is mechanically elegant because it corrects the primary cause, the length discrepancy. The technique involves surgically removing a measured segment of the ulna shaft, typically in the distal third. Crucially, this is an extra-articular approach.
So you're operating well away from the joint itself.
Precisely. By operating away from the joint, we achieve the shortening while completely preserving the integrity of the DRUJ cartilage and the critical, often only partially damaged, TFCC structure. And the benefits are profound. By shortening the ulna, you immediately alleviate the mechanical impaction. Secondly, the shortening reduces tension on the ulnar-sided capsule and ligaments, effectively tightening the DRUJ complex, which is beneficial for stability.
And when we look at outcomes, how reliable is this procedure for restoring function, not just relieving pain?
The procedure is highly reliable. Outcomes data consistently show significant improvement across the board. For instance, studies report that the VAS pain score sees a dramatic reduction. It often plummets from an average of, say, 7.7 down to around 1.7 post-operatively.
It's a huge drop.
A huge drop. And beyond pain relief, patients experience statistically significant increases in forearm rotation and, critically, a substantial recovery of grip strength, which is so vital for quality of life and work function. It is a very predictable procedure when performed correctly.
Are there specific technical recommendations regarding the fixation, for instance, plate placement anterior versus posterior, and the choice of hardware?
Yes. Two specific technical details are highlighted in the guidelines to optimize the outcome and minimize soft tissue irritation. Firstly, it is recommended that the internal fixation plate should be placed on the volar side of the ulna. This placement is associated with less postoperative irritation compared to dorsal placement. That holds a grade B recommendation. Secondly, concerning the hardware itself, the evidence suggests that both locking and non-locking compression plates are acceptable fixation options. The key is just achieving rigid compression across the osteotomy site.
USO is clearly for substantial shortening needs, but what about patients who require very minimal correction? We often rely on the arthroscopic wafer procedure or AWP or other metaphyseal osteotomies. What are the rigid quantitative thresholds that define which procedure is appropriate?
This is where the surgeon's ability to precisely measure that ulnar variance dictates the entire surgical choice. We have a clear algorithm based on the millimeters of required correction. So first, the wafer, or AWP. This involves resecting a minimal amount, typically 2 to 4 millimeters, from the distal ulnar head. It is strictly recommended only for patients with an ulnar-positive variance of less than 2 millimeters.
Less than 2. That's a very tight
A
window.
very tight window, and that's a grade B recommendation. If the anticipated shortening exceeds 3 millimeters, the wafer procedure is strongly not recommended, as it can lead to insufficient correction or even compromised DRUJ stability. Second is the distal metaphyseal ulnar shortening osteotomy, or DMUSO. This is for the middle ground. It's recommended for anticipated osteotomy lengths of less than 5 millimeters.
Okay.
This is performed closer to the joint, often using specialized fixation like buried head compression screws, which are favored as they have fewer postoperative complications. And finally, the traditional USO remains the treatment of choice for required shortening of 5 millimeters or greater.
That quantitative framework is hugely helpful for surgical planning. Finally, let's address the common finding of a concomitant TFCC tear in these patients. Should that tear be repaired primarily, or is it a secondary pathology that just resolves once the length is corrected?
This is a frequently debated point, but the evidence provides a pretty clear sequence of treatment. The crucial insight is that in confirmed ulnar impaction syndrome, the TFCC pathology is often a consequence of the mechanical overload, not the primary driver of instability.
The effect, not the cause.
Exactly. Therefore, it is not recommended to rely solely on TFCC repair for treating confirmed UIS. The clinical data shows that if you only repair the TFCC, a high percentage of patients, roughly 25 to 30%, will require a subsequent USO anyway, because the underlying length mismatch was never addressed. The correct sequence is to address the length first. Perform the ulnar shortening. If, after shortening, the DRUJ stability remains adequate, then no further intervention is needed.
And if it's still unstable?
If DRUJ instability persists after the ulnar shortening, then a concomitant TFCC foveal repair is recommended to restore that stability. This approach ensures we treat the cause before we address the secondary damage.
A very robust, evidence-based roadmap for managing painful wrist mechanics. We move now to our final section, pivoting back to acute trauma, but looking specifically at the ongoing evolution of surgical technique for displaced clavicle fractures, comparing traditional openness with modern minimal invasiveness. For displaced midshaft clavicle fractures, surgical fixation has become increasingly standard. We have compelling comparative data looking at minimally invasive plate osteosynthesis, or MIPO, against traditional open reduction and internal fixation, or ORIF. What was the core hypothesis here, and what are we learning about surgical efficiency?
Well, the core hypothesis was whether MIPO could match the excellent functional outcomes of ORI while simultaneously minimizing the surgical insult. We know ORIF is effective, but it involves significant soft tissue stripping, which inherently risks the blood supply and nearby nerves. The study involved a retrospective comparison of 79 patients, and the data on the surgical trauma metrics was striking. It unequivocally favored MIPO.
How so?
When you compare the two, MIPO achieved its results by drastically reducing the direct surgical intervention. For incision length, MIPO averaged just 6.4 centimeters compared to 12.25 for ORIF.
That's nearly a 50% reduction.
It is. Operative time was also faster, 54 minutes versus 61 for ORIF, and blood loss was also reduced.
That reduction is impressive from a metrics perspective, but how does MIPO actually achieve this? How is it surgically possible to get an excellent reduction in fixation while causing such a dramatic reduction in dissection?
That's the key technical point. MIPO's efficiency stems from its reliance on indirect, closed reduction techniques. In traditional ORIF, we make a large incision, we strip the periosteum and soft tissues away for direct visualization, we manually reduce the fragments, and then apply the plate. This disrupts the fracture hematoma and the periosteal blood supply.
The very things you need for healing.
The very things you need. MIPO, by contrast, uses small incisions proximally and distally. You leverage fluoroscopy and specialized reduction clamps to achieve and hold reduction without exposing the fracture site itself. The plate is then tunneled subcutaneously and fixed. By maintaining the integrity of that soft tissue envelope, MIPO fosters a far better biological environment for healing.
And did that reduction in surgical trauma translate directly to the patient experience in the early phase?
Absolutely. The immediate postoperative phase showed clear benefits. MIPO patients reported significantly lower VAS pain scores on postoperative days 1, 2, and 3. This points towards a much less painful recovery right from the start.
Beyond pain, let's address the most critical complication in clavicle plating: nerve function. Supraclavicular nerve injury, which causes that often frustrating skin numbness over the shoulder and chest, is a known risk of ORAF. Was there a measurable difference?
This is perhaps the single most compelling reason why MIPO adoption should be widespread. The difference in neurological complication rates was dramatic. Postoperative skin numbness, directly linked to the iatrogenic injury of the supraclavicular nerve branches, was observed in 38.3% of patients treated with traditional ORAF.
38%, that's more than a third.
More than a third. In staggering contrast, only 12.5% of patients in the MIPO group experienced this complication. That is a statistically significant difference. It represents nearly a threefold reduction in neurological morbidity simply by switching the technique.
Why such a massive difference? The plate still sits on the superior aspect of the clavicle. Both techniques are working in the same anatomical vicinity. What is ORIF doing that MIPO avoids?
The mechanism of injury in ORIF is dissection, not fixation. The supraclavicular nerve branches fan out over the clavicle area. In traditional ORIF, the surgeon must make a large incision and aggressively mobilize the skin and soft tissue flaps to gain wide exposure. This extensive mobilization inevitably risks traction, crushing, or direct transection of those delicate superficial nerve branches. In MIPO, because the approach uses small portals and the plate is tunneled, the surgeon minimizes the superficial soft tissue dissection required around those nerve branches. The plate is slid underneath the skin through a plane of less neurovascular risk.
So we have reduced trauma, reduced pain, and drastically lower rates of neurological injury. But ultimately, for the surgeon, function is the ultimate arbiter. Were the functional outcomes maintained?
Function was king, and both techniques performed equally well. Functional recovery, tracked using the DASH score and the Constant-Murley score, improved steadily and was statistically comparable between MIPO and ORIF at every measured time point: 6, 12, and 24 weeks post-surgery. Both techniques provide an excellent restoration of strength and range of motion.
But the truly eye-opening statistic, perhaps the most patient-centric metric, is the difference in patient satisfaction. How does the reduced trauma and neurological sparing translate into long-term happiness with the result?
The patient satisfaction data strongly reinforces the importance of minimizing morbidity, even when the functional results are equal. At 24 weeks post-operation, MIPO demonstrated significantly higher overall patient satisfaction, achieving a rate of 90.6%.
90%.
Contrast this with the ORIF group, where satisfaction lagged at 72.3%.
That's a huge difference, an 18-point differential.
It's profound. It demonstrates that patients highly value the smaller scar, the reduced immediate pain, and crucially, the absence of sensory loss. Even if they can move their arm perfectly, if they have an ugly long scar and a persistently numb patch of skin, their subjective satisfaction is significantly lower.
The conclusion is clear then. MIPO for these fractures offers comparable long-term functional recovery, but with significant advantages in quicker operative metrics, accelerated early recovery, a nearly threefold reduction in neurological complications, and demonstrably higher patient satisfaction. We trust this deep dive into these upper limb considerations, from the subtleties of atypical ulnar fractures through the evidence for functional bracing, and the data supporting MIPO for clavicle fixation has proven valuable for your practice.
This really raises an important question we must all consider. As minimally invasive techniques consistently demonstrate functional parity, coupled with superior patient satisfaction and fewer complication risks, how must we, as practitioners, reevaluate our traditional thresholds for open procedures across the entire trauma spectrum? Are we, in fact, ethically justified in continuing to choose a more morbid procedure when a less morbid one delivers the same functional result?
Indeed, that is a challenging thought for us all to take forward. If you found this discussion insightful, please do take a moment to rate and share the show with your colleagues. Thank you for tuning in to Deep Dive Ortho.